Okay, so the risk of cancer death is increased for many of the different kinds of cancer here associated with diabetes. But diabetes is not associated with increased in cancer death for certain types of cancer. Noticeably from, for example, prostate cancer and some of the hematological cancer. But if you look at the cancer death across the board, okay, not about a specific kind of cancer, okay, the mean fasting glucose, which is the mean fasting glucose of 6 is the normal fasting sugar. Okay. So you can see here the hazard ratio of cancer death increases if your fasting blood sugar is not normal. So the diabetes and cancer is associated with each other, and there has been a consensus conference conducted in December 2009, and the results were published in the CA Cancer Journal of Recognition. And this paper basically summarizes and makes some recommendations. The bottom line is that the possible mechanisms for a direct link between type 2 diabetes and cancer is hyperinsulinemia, hyperglycemia, and inflammation. The evidence for specific drugs that are affecting the cancer risk is limited, but they think that there's early evidence to suggest that metformin, which is an anti-diabetic drug that is quite often used in the treatment of type 2 diabetes, this drug, metformin, is associated with a lower risk of cancer, but exogenous insulin, meaning that if the patient needs to ingest insulin for the control of the diabetes, the patient's cancer risk might be higher. So, why does diabetic patients associated with increased formation of cancer, or even after the formation of cancer, the cancer would tend to grow faster, and they have a worse prognosis if they're diabetic compared with non-diabetic patients with the same kind of cancer. This is because of hyperglycemia. As we talked about earlier, that the cancers have this Wolmer phenomenon, and they love to use glycolysis to derive the energy from. So if they take up the glucose very rapidly, okay? So comparing to the surrounding normal tissue, the cancer cells would concentrate and pick up a lot of the glucose. So if you label the glucose, okay, with the F18, which is radioactive fluorine, the fluorodeoxyglucose that's labeled with F18 will be taken up into the cancer cells, right? And then you detect the radiation using the positron tomography. And this picture here is what we call PET scan, okay, positron emission tomography. From the PET scan, you can see that the dark areas are the signals from the high uptake, high concentration of the radioactive glucose. So you can see that this patient with breast cancer, okay, this is background uptake in the liver here, and these very dark dots are actually metastatic foci of the cancer. Okay. So these areas are not specific because these are the radioactive traces that are concentrated in the urine. And this is the kidney pelvis going down to the bladder. And all these dots, each of these dots here represent one metastatic tumor. So when you have high blood sugar in a diabetic, what it means is that you have a lot of sugar to feed these sugar suckers. Okay, it will help the cancers to tolerate hypoxia, help them to become radio resistant, and help them to become resistant to chemotherapy. So with obesity and diabetes, they lead to the high circulating insulin, high IGF-1 signaling, and they through the insulin receptors and IGF-1 receptors that activate the PI3 kinase AKT-mTOR signaling pathway, okay? And they will lead to the cell growth. Okay? And the diabetic medications have different impacts on various points on these pathways. And the investigation how these different diabetic medications have different impacts on cancer cells is my current research interest. So the mechanisms that the cancer proliferation is promoted by diabetes type 2 is that the hyperglycemia, hyperinsulinemia, and high IGF-1. And the effect on the cancer biology is increased proliferation of cancer cells and resistance to apoptosis, leading to chemoresistance and radioresistance. Now, very often, cancer patients would have difficulty taking in nutrition. Okay? Like for example, if their bowel is obstructed, they cannot eat or drink. And in those cases, patients might need to have the nutrition given to them through the vein, called the total parenteral nutrition. Okay. So there has been studies to look at whether the total parenteral nutrition, which is very concentrated in nutrients and high concentration of calories, if you give the patient the TPN, the total parenteral nutrition, what type of impact does it have on the cancer cells? Okay. So here, with the patient on TPN only, we're looking at now the percentage of the cells in the cancer that in the S phase. Okay. Dr. Lee talked about the cell cycle. The S phase of the cell cycle means that the cells are proliferating, they're synthesizing and dividing. Okay. So with TPN, okay, the increase in the fuel, the energy supply, okay, and then also when you have putting in so much concentrated energy, nutrients into the body's response to handle these nutrients by secreting the insulin, by secreting IGF-1, and so indirectly you also stimulate increasing the IGF-1 and insulin in the blood. So you can see that the proliferation of the cancer cells is increased by the TPN. Okay. So this increase in the proliferation is somewhat suppressed if you give the patient chemotherapy together with the TPN. Okay. So this is for comparison, okay, that if you give chemotherapy alone, okay, the number of S cells in the S phase is slightly lower, and this is to control the number of cells in the S phase. Patients that are not receiving TPN nor chemotherapy. So, although sometimes the TPN may help the patient to survive in the short term, in terms of when the patient has difficulty taking in nutrition, but in the long down the road, it may accelerate the demise by stimulating the cancer growth. So, in terms of the recommendations on nutrition and physical activity for cancer prevention purposes. The American Cancer Society have come up with some guidelines. Their recommendation is that be as lean as possible throughout life without being underweight. Underweight is bad because you have increase in all-cause mortality. But being lean and within the normal weight range with a normal body mass index is recommended. Engage in a regular physical activity and limit consumption of high-calorie foods and beverages is a key strategy for managing a healthy weight. Okay. So, Diet Coke or no Coke at all. Adults should be engaged in at least 150 minutes of moderate intensity exercise and 75 minutes of vigorous and high intensity exercise per week, or an equivalent combination and preferably spread out throughout the week. So it's been demonstrated that, in a recent paper, that the greater adherence to the ACS guideline of the nutrition and physical activity for cancer prevention is associated with lower mortality from cancer, cardiovascular disease, and all causes combined. So this is most important, all causes combined. So I guess that is the wisdom for trying to live longer for longevity. So weight loss, cancer and cancer treatment can have significant effect on the host metabolism. And cancer can induce weight loss. Weight loss is very often the first symptom at the time of diagnosis. Almost like 30 to 80% of the patients at the time when the cancer is diagnosed, they would report that they have been losing weight. Sarcopenia is a problem associated with cancer cachexia. Cancer-induced insulin resistance and diabetes. Okay. Some cancers in particular can induce insulin resistance and diabetes, and that is pancreatic cancer. And this is still an area of active investigation. Although the pancreatic cancer is associated with the insulin resistance and diabetes, exactly how it happened, what type of mediators are involved, is still under investigation. The cancer cachexia syndrome, patients with cancer would become cachectic, and the mechanisms are most likely involving the inflammatory cytokines, but there are perhaps some yet unknown humoral factors involved, and this is also an area of active investigation. The glucocorticoid-induced insulin resistance and diabetes. Glucocorticoids are very often used in the treatment of the cancer, and when used in high doses, they can lead to steroid-induced diabetes, and I am doing some research right now that have data to show that in myeloma patients, that steroid-induced diabetes is associated with poor survival of these patients, and we're in the process of writing a paper to publish those results. Now, the cancer surgery, okay, like for example, if you have to remove the pancreas, remove a big part of the pancreas, then you lose the ability to secrete insulin, and that can create a insulinopenic type of diabetes. And for prostate cancer, very often they would need chemical castration. They use drugs to suppress the androgen production. Okay, in those patients with the loss of androgen signaling, they would also induce insulin resistance and leading to insulin resistant type of diabetes. And weight gain after chemotherapy. This has been reported in several types of cancer, and especially breast cancer. For some reason, still yet unknown, unclear, that after a patient had surgery and chemotherapy for breast cancer, the breast cancer patients tend to gain weight. Sometimes to very significant degrees, and the patient will become obese actually. So, weight loss, the nutritional status, of course, would influence the clinical prognosis. Weight loss would reduce survival. It would increase the treatment-related adverse reactions. It increase the risk of perioperative complications. Now we're talking about some practical use of the clinical implications of the cancer cell metabolism. As I mentioned earlier, the positron emission tomography is a very commonly used these days. It's a very useful type of imaging method to take advantage of the characteristic of the cancer cells to take up glucose to detect metastatic cancer. Okay. Now, the U.S. now is really routine imaging using this for staging purposes to see if the patient already has metastatic cancer in order to make plans for the treatment of the cancer. So in this picture here, this is showing that the patient has metastatic cancer here in these stark spots. Okay. Now, there's also new types of imaging taking advantage of the ability of the cancer cells to take up glutamine. Okay. For example, it is experimental PET imaging now of the glutaminolysis in tumors by using the F18 labeled fluorogluten. But this, at this point, is not in widespread clinical use. But the glucose, fluorodeoxyglucose PET scan is in widespread clinical use. Also, that with the energy metabolism, we can target it using drugs to take advantage of the Achilles heel of the patient, of the cancer cells, to treat the cancer. The mTOR inhibitors, as I mentioned earlier, the AKT-mTOR signaling pathway is the key pathway that leads down to the regulation of the energy metabolism, especially the glycolytic pathway. And everolimus, or RAC001, is recently, and also the temozolomus, CCI779, these are the so-called inhibitors of mTOR. They are the analogs of rapamycin. HIF inhibitors, topotecan, NSC 644221, YC1, PX478. These three here, not except for topotecan, these three are still investigational drugs. The glycolytic inhibitors, okay. Free bromopyruvate is a hexokinase inhibitor, so this can increase the flux through glycolysis. And this drug is experimental and is undergoing clinical trial right now. So there are other metabolic inhibitors. There are drugs that are being investigated for the inhibition of glutaminolysis. There are also inhibitors that would deplete ATP or pyrimidine. These metabolite analogs are quite toxic, so it's mainly for experimental purposes at this point. It's not in clinical trials. The AMP analog is the so-called ICAR, 5-amino imidazole 4-carboxamide ribose. This mimics the AMP and sort of fool the cell that the patient, the cancer cells are in a low energy state, and they would activate the AMPK signaling pathway. So fatty acid synthase is an important enzyme for the de novo lipid synthesis by the cancer cell. So this is a very unusual protein or enzyme. This is a one gene, one protein, but has multiple enzymatic domains. It exists as a homodimer of two identical 272 kilodalton multifunctional polypeptides. Now this multiple functional domains, it has KS, MAT, pH, etc. Okay. H stands for the beta ketoacyl synthase. Okay. MAT, malonyl acetyltransferase, dehydrase, enol reductase, alpha ketoacyl reductase, acyl carrier protein, phytoesterase, all these different domains as depicted here on this diagram. And there are the substrates are actually handed from one domain to another to complete this fatty acid synthesis process. The synthesis is coming from starting from acetyl-CoA and malonyl-CoA in the presence of the coenzyme NADPH, and they ended up with a pharmacant. So in this cartoon here, this diagram shows that there are so-called fatty acid synthase inhibitors that works by inhibiting different domains or different specific enzymes, specific enzymatic domains on this fatty acid synthase. And the EGCG, the epigallocatechin 3 gallate, this is actually an inhibitor of the fatty acid synthase. And this is actually one of the ingredients from green tea. Perhaps green tea has some activity in terms of cancer prevention. So when the fatty acid synthase is inhibited, the cancer cells would undergo apoptosis. So this is the pathway to demonstrate the involvement of the AKT, involvement of CPT11, and activation of the apoptotic pathway. So now, next we talk about the methodology of the investigation of the cancer cell metabolism. So a lot of times, you can look at things with a telescope. We're looking at things from far away, but looking at whole things as a whole. Looking at the whole planet, looking at the whole galaxy. Or you can look at things with a microscope. We'll look at things with electron microscope, looking at things at the subcellular level or even molecular level. So in order to look at the big picture, so we have the so-called the different types of omics. Okay. So we look at it starting with the genome, starting with the transcriptome, and then the proteome, and then the metabolome. So with all these different, from the DNA to the RNA to the protein and to the metabolites. Okay. So you look at using the comprehensive approach to look at the big picture of all these different individual pieces of data. So we come up with big databases of data, and from there, how do you make sense of it? What information do you extract from it? So you have to look at what is your question. You take different groups, different populations, and again we go back to statistics and the numerical handling of all the data. How do you extract the data to find correlations, to find patterns in this immense amount of data, to make sense out of it, to generate biological knowledge, so that the knowledge can be used for